Welcome, M3 students. I'm Adjunct Associate Professor Renaud. Today we'll take a case-based approach to acid-based and electrolyte disorders in this 9-minute masterclass. This clinical approach ensures you master the foundational principles of homeostasis while building a systematic framework for tackling complex metabolic cases. First, let's review the 4 laws of homeostasis. Serum osmolality must be maintained around 285 milliosmoles for osmotic equilibrium, preventing cell swelling or shrinkage. Second, pH balance must be strictly kept between 7.35 and 7.45. Third, electrolyte gradients across membranes are vital for resting potential, as described by the Nernst equation. Finally, electroneutrality. Cations must always equal anions. This principle is fundamental to our diagnostic framework for approaches to metabolic acidosis. When pH drops, the body's defense is tiered. Chemical buffers and the respiratory system respond immediately, but the kidneys manage long-term regulation. The bicarbonate buffer system combines protons and bicarbonate to form CO2 and water. This consumes bicarbonate, creating a debt the kidneys must repay. Repayment happens in the nephrons, where bicarbonate is regenerated and protons are excreted through titratable acids and ammonia trapping. We estimate urinary ammonium using the urine anion gap. A positive gap suggests a distal tubular problem, specifically a failure to acidify the urine. To work through these problems systematically, use this 9-step checklist. Start with pH, check the bicarbonate, and evaluate the adequacy of the PaCO2 compensation. The checklist continues with calculating the anion gap and, crucially, adjusting for albumin. A high gap leads us directly to the gold mark mnemonic. Differentiating RTA types is critical. Remember that type 1 distal RTA is defined by a positive urine Ag and a urine pH that fails to drop below 6. This clinical table separates DRTA from PRTA and GI loss. Note that type 1 or DRTA is unique in its association with renal calculi and nephrocalcinosis. In case 1, our 45-year-old female presents with limb weakness. Her CT cube shows nephrocalcinosis, a hallmark indicator of distal tubular dysfunction. Labs show a normal Ag metabolic acidosis with a pH of 7.26. The positive urine Ag confirms the diagnosis of DRTA, secondary to Sjogren's syndrome. Case 2 features a significant high anion gap metabolic acidosis in a 21-year-old male. His anion gap of 25 demands a systematic clinical investigation. For HAGMA, we now use the gold mark mnemonic, the millennial version that avoids redundancy. In this patient, diabetic ketoacidosis is the primary cause. Case 3 shows why we must always correct for albumin. An anion gap of 16 seems normal until you see the albumin is only 10 grams per liter. The large osmolar gap revealed ethylene glycol intoxication. Always remember, for every 10 gram per liter drop in albumin, the baseline Ag drops by 2.5. Moving to disorders of sodium. Hyponatremia is primarily a disorder of water metabolism. We must first determine if it's a true hypoosmolar state. Rule out pseudo-hyponatremia, where high lipids or proteins artifactually lower the sodium measurement despite a normal plasma osmolality. Importantly, hyperglycemia causes a true translocational hyperosmolar hyponatremia. The high glucose pulls water from cells, diluting the serum sodium. The Edelman equation shows that plasma sodium is determined by the ratio of total exchangeable sodium and potassium to total body water. Why do we worry? Acutely, it leads to cerebral edema. Chronic states result in cognitive impairment, gait disturbances, and increased fracture risks. Case 4. An elderly woman on thiazides presenting with a sodium of 105. This severe chronic hyponatremia requires an extremely slow rate of correction. The brain adapts to chronic low sodium by shedding osmolytes. Correcting too fast reverses this abruptly, leading to the specter of osmotic demyelination syndrome. Stay below 6 millimoles per day for chronic cases. Rapid correction is reserved only for severe acute symptoms where cerebral edema is the threat. Case 5 features a patient with a sodium of 119. His urine osmolality of only 78 tells us that ADH is appropriately switched off. With low urine osmolality, consider primary polydipsia, beer potomania, or low solute intake. Note that SIADH is actually rare in these clinical contexts. Hypernatremia, sodium over 145, is always a water deficit problem. Thirst is our most potent defense, so it primarily affects those who can't call for water. Management requires calculating the total water deficit. Restoring balance safely involves using hypertonic fluids like free water or D5W. Case 6 features a patient with sodium over 180. His high urine osmolality rules out diabetes insipidus, confirming severe volume contraction. We calculate the water deficit, which for this patient is approximately 10 liters. Management focuses on systematic restoration of balance. New data suggests that in adults, we don't need to fear rapid correction of hypernatremia as much as we do for hyponatremia. Fast correction may even be beneficial. Turning to potassium. We must separate translocational shifts from true body deficits by evaluating the volume status and the acid-base state. Check the acid-base status and volume. This systematic approach differentiates between adrenal excess and renal or GI potassium losses. Case 7 is a hypertensive patient with low potassium. Evaluating the renin-aldosterone axis is mandatory to confirm primary hyperaldosteronism. Low renin and high aldosterone confirm Conn's syndrome. Use this roadmap to differentiate between the various hypertensive hypokalemic presentations. The Nernst equation explains why translocational shifts cause symptoms by hyperpolarizing the membrane. In contrast, contraction alkalosis, however, often remains asymptomatic. In Gittleman's, proportionate loss prevents changes in the resting membrane potential, keeping patients asymptomatic despite very low potassium levels. In hyperkalemia, check for tented T waves. A good dietary history is vital here. Ensure the result is real and not due to lysis or EDTA contamination. Rule out the rare EDTA effect, which artifactually lowers calcium and raises potassium. Always confirm with a heparinized tube if hemolysis is suspected. When treating with insulin and glucose, perform glycemia checks both before and after treatment. This is critical to avoid iatrogenic hypoglycemia. For therapy, we use Resonium for acute management and Lokelma for chronic treatment. Mastery of these cases ensures precision in your clinical practice. Good luck on the wards and with your studies. I'm Adjunct Associate Professor Renaud. Thank you for joining this masterclass.